All right, let me convene us. So good afternoon, everybody. Welcome. Thank you all for joining us. For those who I don't know and those who are on the web, I'm Sandro Galea, and I have the privilege of serving as Dean of the School of Public Health at Boston University. And it's my pleasure on behalf of the school to welcome you to today's Dean's Seminar. Public health is global health. You just have to remember that the failure of health systems in West Africa resulted in Ebola in Texas, that wars create refugees who carry into new countries the trauma of their experiences, and that threats like climate change and global inequality undermine health across countries and continents. Improving these conditions means working with governments and international bodies to implement solutions, which is one of the core functions of the World Health Organization. I think there are very few people who actually understand this work better than Agis Tsouros. Dr. Tsouros is currently an international advisor on health policy and strategy. Before that, he was Director of Policy and Governance for Health and Wellbeing at WHO Europe, and he also served as Director of the Healthy Cities Program at WHO Europe. Dr. Tsouros had a 27-year career working at the intersection of public policy, intersectoral governance, urban health, and the social determinants of health and health equity. He also has done some very cool things, like being seconded to the Greek government to lead public preparedness for the 2004 Athens Olympics. He established the Global Healthy Cities movement to promote strengthening healthy cities and is currently in the process of relaunching the World Institute for Cities Diplomacy. Today, he's going to talk about all of this, but in particular about his career, discuss how public health can continue to meet the needs of our changing times. He's going to address the barriers we face as we aspire to create health and how we can promote evidence-based political policies to meet the challenges of our time. On a personal note, I've enjoyed and learned from my many interactions with Agis over the years, and I'm very much looking forward to hearing his talk. Dr. Tsouros.
Is it working? Yeah. Time remaining 45 minutes. So, dear colleagues, dear friends, dear Sandro, thank you very much for this invitation. I'm really honored to be here. And you believe it or not, it's the first time that I was forced to sit down in the last week or so and think about this period I spent training for public health, working within WHO, engaging with many partners, many countries, and try to reflect once again, now having distanced myself somehow. I've left WHO a year and a half ago, and think what I would like to share with you that should be of some value and importance in your careers and in your work in public health. I like always to say something which some of you may have heard already, which is when I finished my medical school in Athens, in Greece. I come from Greece. I was good in clinical medicine, and I intended to pursue a clinical career. My father was a radiologist. I wanted to do something more in surgery. But I always had this special interest in politics and the social dimension of health. However, I couldn't imagine at that time, besides my, let's say, academic interest in this field, I couldn't imagine a career in this until a friend of mine who had just finished a doctorate in the UK, he told me that, you know, you can study social medicine if you want. That's what public health was called in those days. It was social medicine that was later converted into community medicine and then became public health medicine and public health as it is today. So what I wanted to mention to you is that when I announced to my family that I was going to study public health and abandon my clinical medicine plans, my mother cried. It was a great disappointment. It was an absolute disillusionment how Agis, after all these great grades in clinical medicine, is going to do something which, remember, in those days, not that it is very different today, but in those days, many people only associate it with hygiene and sanitation. So if you said you're going to work into public health and so on, that's what it meant, and that's why my mother cried. Not that she thought that sanitation was not important, but somehow it was not the brilliant career that she had envisaged for her son. So that's how I got. So I had to follow the voice of my heart to travel to the UK. I had a scholarship, and that's how that path in my life started. And I have to tell you that very soon I felt that I had made the right choice. I would say in the first few months, doing my master's, I felt this is great. This is a blessing. This is something that is going to change my life. So that's the start. I say this because I can't tell you how passionate and how proud I am, and I have always been, for pursuing a career in public health. Having said that, I have also lived and I have witnessed in many countries how anemic, how weak public health is perceived to be, how second-class citizen kind of status it's got in many countries, and sometimes you are even forced to lie and say that you're doing something else in medicine to avoid any further explanations why and what it is that you're doing in public health. Having said that, I think working in public health was, and today especially, it's one of the most promising and exciting areas that you can work, and it has a wide range of pathways that you can follow, from local to national to global, and across many disciplines and fields. In this presentation, somewhere in my pocket I have this, yeah. So I don't have many slides to show you. I generally hate PowerPoints, but I will just show you only a few and share my thoughts on these three aspects. I wanted to follow this career that I'm going to talk to you about, not so much talking about myself, but explaining and sharing with you what happened, what were the really significant changes that happened in public health in the last 30 and 40 years, and where we are now, and what are the big challenges. So I want to talk to you a little bit about the dawn of a new public health era, and what I mean by that. 30 years of change, mainly working through an international organization like the WHO, and public health in the 21st century, and what it is that we have to face, and how we can prepare for what is to come, and how we can mainstream public health, how we can get the idea of health and in its full meaning in the DNA of our governance systems. Now, I start with the dawn of a new public health to say that it's very interesting that you have a period which is started in the 60s and then early 70s with a strong questioning of traditional medicine. So you had people like Ivan Illich, Cochrane, McEwen, a lot of people who begin to question. Of course, there was also a financial crisis in around 72, 73, and the exponential cost of medicine was a big concern for many governments. But nevertheless, many people were questioning the effectiveness of medicine. Hence, Cochrane is talking about effectiveness, trials, and so on, looking at long-term trends, maybe discovering that we were overselling the effectiveness of medicine. So we come during a period in the 70s where many movements spontaneously rethink medicine and health. The women's movement in the 70s had a huge impact on the way health policies and thinking was shaped. And then we come to 1978 when we have the famous Alma Ata. This year we celebrate 40 years from the Alma Ata Declaration, launching a new concept of primary health care. It was really changing a paradigm in medicine. It was not just drawing attention to the importance of that level of healthcare, but it was very important at that time to say, hey, community participation, equity, multidisciplinary work, prevention, and a whole range, intersectoral collaboration and so on, were so important for health. And soon after that, in 1980-83, you have the launch of the Health for All strategy. The strategy Health for All, which was the first time that you have a global framework for health, which was value-based and which was addressing all the significant aspects of health on the planet. Well, this was the dawn of a new public health era. Because at that time, Health for All, Alma Ata, a little bit later, the Ottawa Declaration of Health Promotion, 1986, they culminate a wealth of new evidence which was demanding a new way of thinking and rethinking of health systems, of health development, of health promotion. It's not at all accidental that a big influence on the Health for All movement was also the research that was the outcome of the research from the Black Report in 1980 in the UK, which was on the health inequalities. So now I will be zooming in and out to talking about this period and also talking about my path. I find myself in the 80s in London being trained in public health. There is more schools of public health per square mile than any other place in the world, I think, just because there are so many medical schools, and there were many more then. Now they have merged them into fewer, and the School of Hygiene and Tropical Medicine and so on. So there were a lot of discussions at that time about this new paradigm of health. And remember, in those days, it was a Thatcher government in power. You were not allowed to talk about inequalities. It was a big no-no because there was kind of resistance to accept that there was a link between unemployment and health and so on. I will not talk much more on those issues, except to say that there was the 80s, it was all of a sudden a time when working in public health was quite inspiring and exciting, because you were called to not just deal with traditional communicable diseases, epidemics, or all sorts of other issues which were more traditional, but what this new public health era did is it attracted, it legitimized the involvement of many new actors. So you all of a sudden had not only the doctors or some traditional environmental health officers and others, but you had a whole range of professions who all of a sudden understood that they had a role within the health promotion movement. Remember that this is the time when we talk about healthy settings, the various areas where you can develop health and organizational development for health, and so on. So it is at that time that I joined WHO. So I joined WHO at a time when the head of the organization was a man whose influence has been an inspiration on almost everybody who has worked in public health. His name was Halfdan Mahler. He was the Director General of WHO when Health for All was launched. It was just listening to this man, you would just melt and you would just be inspired for life to work for public health. And I'm not exaggerating, he was a unique person to have and to look up to within the organization. But what was the most important is I find myself joining an organization that was ready to breathe fresh air. It was ready to allow experimentation and innovation, and let's do new things. Let's try different things. This is how Healthy Cities was established. Because remember, what was very unusual is that normally UN agencies like WHO are actually agencies that are obliged to work with national governments, not with subnational or. And in fact, the real counterpart of WHO's governing bodies in practice is ministers of health. In theory, you could say also foreign ministers, but it doesn't happen in practice. So it was quite a courageous move for WHO in Europe to say, well, we believe in local action, we believe in the importance of the urban context, and we believe in the key role of local governments, mayors, and others to work for health. So let's go out to them. And what was very interesting is that in the beginning, this idea of healthy cities was meant to be an experiment. Let's reach out to a few cities. Let's do a pilot, and if it works, then we can scale it up. Well, in those days, there were no social media, but what happened is the idea became viral. I mean, the first 10 or 11 cities that we wanted to have became 35 and 40. They all wanted to work, and within 2 years, there were more than 200 cities in Europe demanding to work on this. You didn't need to explain to mayors, and that's interesting when we talk about health. And that's one of the lessons I learned. In the beginning, there were people who were saying, oh, but yes, in Scandinavian countries, mayors also have responsibility for health services. But in the South, they don't. So how do you expect mayors to work on health? Well, while we were trying to figure out ways to explain this to mayors, mayors had already understood that health was much bigger than their health services, that health is everybody's business, and they undertook to make this a priority in their cities and work for healthy cities, irrespectively whether they were Barcelona, Copenhagen, Stockholm, Rennes, Athens, or whatever other city. So the lesson that I drew from that explosive expansion of healthy cities is that sometimes in our work we have to think big. We have to take some risks in terms of working outside the comfort professional zones. You know, let's talk to the doctors, let's talk to the Ministry of Health and so on. Something that I often say to colleagues is, if in 1988, when I joined WHO, you invited cities to send a representative, invariably they will send a cardiologist. Okay? But 5 or 10 years later, they will send an urban planner. They will send an architect. They will send a social worker. They will send a variety of professionals who were not necessarily what you would call the traditional health professional. Now, that was very significant. And imagine that at that time, WHO begins to launch a series of such initiatives, healthy schools, health promoting hospitals, healthy prisons, you name it. All of a sudden, health was to infiltrate and be part of many initiatives which inevitably will spread into other sectors and other domains. So, this is a time also that other paradigms came into redefining this, scene. The AIDS epidemic changed totally the paradigm of the provision of health care. All of a sudden, you know, all this talk about patient-centered approaches and so on changed, demanded that this was a social disease. This was something that could not be dealt with traditional ways. So there you have another kind of wave of change which impacted a lot the way we were working with our member states. So at the same time, and this is, if you like, in the European region, for me, that was the turning point. Is I joined in '88 and '89, the Berlin Wall fell. So all of a sudden, we had a region there, I can't remember, we had 36 member states in the European region. So you can imagine Russia was a huge bloc, the Soviet Union. And overnight, I mean, today we have 53 member states. The breakup of the Soviet Union, the breakup of Yugoslavia, other little states here and there, it became a huge and diverse region. But what was amazing was this, to work in a region where we had all this air of change on one hand, and then you have these vast geopolitical changes in the European region, and where we had to work step by step and work with all these countries. Now, another lesson drawn in my work is don't make assumptions about anybody that you understand. Don't think that the same terms are understood the same way in different cultures. So I organized a conference in Hungary in 1989 on community participation and democracy. Believe me, the way participation was understood in Hungary, and the representatives from all the neighboring countries former under the influence of the Soviet bloc was very different to that of our Western partners. But Healthy Cities created a platform of dialogue. Through osmosis, all of a sudden, you could see that the rich and the poor, the former East and the West, the North and South, they started developing a common language, a common understanding. They were no better or worse. They were just people from the real world who didn't come to a conference of Healthy Cities to talk about chi-squares and deviations. They came to talk about the politics of health. They came to present their concerns, the local concerns, the local priorities, and to look for innovation, for advice, to share experience, and shape a common future as European citizens. And this is what happened. And believe me, although you can say I was locked in an ivory tower working for WHO all these years, my sanity was preserved by working with cities, because I could see what's happening on the ground. So yes, I was flying in and out, but by working with communities and with cities, I could smell, I could feel, I could hear, I could see what were the concerns of real people across my region. And that was a message that was coming back into the organization. And if you like, could influence what we were doing to be a little bit more realistic, to be a little bit better tuned to the expectations of those people. So, An issue that it's a great concern of mine, and it has influenced my career from the beginning, has been this. How do you bridge the gap, and how do you accelerate implementation of scientific knowledge into the policy domain? And I was always bewildered by the fact that, you know, Richard Dole spoke about cancer and smoking in the 50s, and it took us 50 years to develop the Framework Convention for Tobacco Control. 50 years, while we had pretty strong evidence for many years. Inequalities in health are spoken about for at least 40 years now. Where, colleagues, there are only a handful of countries in the world that are working seriously on the social determinants of health and on inequalities. Something is missing here. Why is it that everybody is smart, everybody will say, yes, we are for equity, yes, we are for human rights, but when you read this in the preamble of the documents, but when you look through the documents of what they do, you're surprised how little they do. Lip service to great concepts. Why? Why do they all think that inequalities and social determinants is only working for vulnerable groups and nothing else? Why some think that this is only an issue of access to health services? Why, in the 21st century, traveling to many of the countries, I would be met by officials from the Ministry of Health, and they would say to me, Dr. Tsouros, there are two words you should not be using when you meet the minister or others, equity and poverty. But I'm here for equity and poverty. Well, you have to find other ways to talk about differences and so on. What I mean by that, for us as public health advocates, because you are in the School of Public Health, and I don't want to be very radical, but my definition of public health is 50% politics, 25% is your ability, your art, to make a change and to work in a given context, and the other 25% is science, which of course you have to be solidly on the ground. And I say politics because a lot of what we know today, what are the most modern concepts of public health today? Certainly, I would start from our knowledge on the social, the economic, the political, the commercial, the cultural, and so on determinants of health. But I also made another mistake. I was thinking that the more knowledge we will have, the more implementation we will have. Because in the 80s and 90s, everybody was critical to WHO, and they were saying, well, you advocate equity, but this is ideological. This is socialist stuff. You shouldn't be talking about this because the evidence is not so hard. Okay, Mr. Minister, but now we are drowning in evidence and still there is no action. Why? What are we missing? Why so many great concepts in modern public health? Whether we talk about health literacy, whether we talk about equity, whether we talk about community resilience, we talk about the LifeCourse Approach. I hope you all know what is the LifeCourse Approach. It's essential in implementing our knowledge on the social determinants, what it is to work on upstream, the distal determinants as opposed to the proximal determinants and so on. You know, that's another issue. I think sometimes we have tended to super-intellectualize our science. We made it difficult. It's very comfortable to talk amongst each other and to talk about these things. We all read the same literature, more or less. We can nod and say, yes, I know what you're talking about. But do you know what I say to Michael Marmot, with whom I have been associated for many years, who is one of the gurus of the literature on social determinants and inequalities? I say to him, Michael, you get again and again standing ovations in conferences when you speak to public health audiences, which is absolutely great. But I would like us to I would like you to get stand innovations addressing a group of ministers of finance, of representatives from the education, from the social, from other sectors. Because, and this is a lot of what I want to also share with you as we want to look into the future. I will show you some slides to see what are the current priorities of WHO. If you look at most of the priorities, the public health priorities of our time, they all call for intersectoral action. They all call for a whole of government approach. You will find many people will say to you today, and I agree with that the Sustainable Development Goals, the SDGs, are a great support to a public health agenda, to put health high on the social and political agenda. But to implement the 17 Sustainable Development Goals, you have to develop a culture of governance for health. You need appropriate leadership. And when I say governance for health, I don't mean health governance, which is mainly how you manage the health system. I mean, you need to have the ability to integrate into the way you govern by putting health as a high value in the way you want to see the future of your city, of your country, of your region. Because health is very closely also linked to social, economic, and sustainable development. This is not theoretical, colleagues. It's very easy to consume all your life as public health practitioners doing things that you feel you have full control on. You know, you're managing a communicable disease epidemic, or you're managing something which is totally within the boundaries of your jurisdiction, let's say. But the most challenging aspects of public health today are actually demanding a high-level involvement of whole of governments, of many other sectors. Now, here is another, I call it a joke. When I was developing the European strategy 2020, and we were looking into literature and references and so on, I discovered on a dusted shelf in my office in Copenhagen a book which was called WHO, sorry, I'm lying. It was WHO, UNICEF, UNESCO, you name it, how many logos on the cover, Intersectoral Collaboration. I thought, wow, 1986 dated. Well, I went through the pages, and I have to tell you that book could have easily been written today, and it would have been very credible. If you, what do you say in the United States, if you whiten out, you know, this white stuff that you put, you know, if you had put this white stuff, we call it Tipex, on the pages where there was the date, you could have easily fooled someone that, that this was produced so many years ago. Again, I have this sinking feeling, and I say, well, why? Now, we have slowly come to a realization that maybe we became too imposing by telling other sectors what to do. We discovered the impact on health of the policies of other sectors, but the way we're trying to get them to work with us was not appropriate. Today, we talk more about win-win situations. We say to the other sectors, what can you do for us, and what can we do for you to promote your policies? Another big issue is in trying to sell to decision makers this idea of health is everybody's business. we very often tend to tell them that they have to establish intersectoral committees, they have to do this and that. So we focus too much on mechanisms, but we don't explain to them clearly what it takes to work with other sectors on the policy level, what it takes to work with other sectors on the strategy level. And I have to say that we have failed also in WHO very often in our ability to sustain action in countries. So you have your 5 minutes with the prime minister, you have your half an hour with the minister, you get them convinced that they have to do something about, let's say, inequalities in health or some other aspect. You get them, you convince them to establish some mechanisms, but you don't give them a well thought through framework that they can use to continue a sustained kind of engagement at the political level to work on health, equity, and sustainable development. So, what is the reality? The reality is that this applies to WHO, this applies to many others. Science has advanced a lot, and we have produced a lot of exciting new concepts in public health. We have done that. And you can fill your heads with all sorts of great ideas that you could hopefully apply when you become practitioners. But it is, I often use the analogy of software and hardware. We developed great new software, but our hardware, which is the way we are organized, our organizations, our societies, is outdated. So it's like trying to install a Windows, whatever is the latest, on a computer which was built many years ago, and it wouldn't work. So basically, there is a difference. Even within the organization, WHO, you will, I mean, I'm allowed to say that now, in the sense that, we need always to also, you know, look inside, not only preach and promote ideas to the outside world. WHO can be as siloed as any Ministry of Health, as any School of Public Health, as any kind of institution out there. So the paradox, we promote ideas that can only be implemented fully through horizontal ways of working, through new governance, through a leadership which is different to the leadership that we have had until now, but we don't do it. But we don't do it. And many of these ideas will continue to remain unimplemented. I want to see also how, right. Yes, I had a little story just to tell you in between, making assumptions. In the 90s, I was working a lot in St. Petersburg in Russia, and I went with a colleague, Marty Wagner, who was responsible for maternal health. And we visited, St. Petersburg was one of the first cities in the Healthy Cities movement. Had a charismatic governor, Sobchak, fully committed, a lot of energy. So anyway, we went with Marty to visit a teenage girls' center. And it was one of those centers that young girls will go and seek advice about birth control and all sorts of related issues. So we go there, and it was really a very dark place. And Marty, who was very enthusiastic, and he said, look, guys, if you really want to make this place work, what you should do is you should paint the walls bright colors, change the furniture, put Madonna's pictures on the walls, and then it's going to be an attractive place. indeed, 3 months later, we went back with Marty and we visited this center, and the center was transformed. It was bright colors and white and can't remember, sort of pinky, nice colors and young colors. And there were also pictures of the Madonna on the walls, with the only difference that they were Leonardo da Vinci's Madonna. In the sense that in that, because as you know, in Hermitage they have famous Madonnas of Leonardo da Vinci, and and I mentioned this as an example of how we can sometimes make assumptions which cannot always be understood in the same way, and this is a light example. There are huge differences in the understanding, even today, across a region as diverse as the European region. What is human rights? What do we mean by equity? What do we mean by the right to health? And what do we mean by respecting the rights of people of various sexual preferences, the needs of older people, and so on? So, some lessons learned to some conclusions to give you. This is a slide. I will give this PowerPoint. You can see it afterwards at your leisure, with some of the big issues today that relate to the evolution of our understanding of health over the past 30 years, the values and what society we want. I like to underline something which is based on where we are today. Health is a political choice. This is what it is. And there are many reasons, and I have also a slide to explain this, why those big decisions have to be made at that high level, and why, following from that leadership, you need to revisit your governance structures if you really want to be true to the promises you are making about implementing those issues. The other issue is capacity to implement. I mentioned it before, I say it again. Public health systems in most countries are really outdated. You cannot implement a modern public health agenda with systems that are so old, and also whose practitioners. I know in this school, and I have heard Sandro talking about it, you talk a lot about the public health practitioners of tomorrow. You know, what are the skills they should have? What are the abilities? What are the tools they should be equipped with to be effective in what they do? This is very important. This is from the literature on 21st century approach governance to health. This is from Michael Marmot's The Social Determinants of Health and How and Where We Should Be Acting. Always remember the Sustainable Development Goals are essential and very helpful politically to mobilize a country. I mean, if you say, for example, for me it's one of the most formidable goals for a country to say, we want to give every child a healthy start in life. This is core social determinants research. This can only be defined as a goal by a government. This is not the Ministry of Health. But if you do that, you will have then the legitimacy to establish committees, mechanisms, and other. But you need to define what sort of society you want to have in the first place. I give you why health is a political choice, why health is now on the global agenda. I don't want to go into this, but we work today on health diplomacy. You see that health is now on the agenda of the G8 and so on. It used to be a secondary issue. Today, health has reached the strata of the leaders of the world, but we don't have in countries and in the global health architecture yet effective mechanisms to make the necessary improvements that we need to make. This is WHO today. Again, you can look at your leisure. But as you see, basically, everything is there. This is the new program of work of WHO that was endorsed by the member states in May this year. So you can see the usual things: universal coverage, health emergencies. I have to say a big issue today in the world is preparedness to deal with the consequences of climate change, of disasters for which we need to have mechanisms in place, whether at local level or at national level, and healthier people. Otherwise, you're going to see all the right talk, you know, whole of society, life course, determinants of health, health in all policies, you name it. What is, and I tell you this because I've been working with those issues for so many years, is yes, okay, but how do we do it? Or when the politicians say, where do I start? And we need to be really better at explaining, at brokering those ideas, and also at helping decision makers create the appropriate governance for the new public health. Approaches and priorities that matter. So, talking about public health, as I said, is a political issue. You need to make the appropriate political choices explicitly. You need to make strategic choices. You know, it's not enough to tell me what you want to do. I want to hear how you're planning to do it. Strategic means what are the interventions that will give you the maximum impact. Many people think strategic is to just concentrate on some proximal interventions. This will not have a long-term effect. And of course, you have to adapt your organizations. So understanding the global health architecture, the importance of value-based visions, the legitimacy of the SDGs that you get added, the preconditions of effective leadership and capacity for implementation, systematic, strategic, sustainable, more need for evaluation, but which is both quantitative, qualitative, and anticipating change. So in a nutshell, I think we have great evidence today. We have many more actors at global level. You know, a few years ago, it was only WHO. You know, it was moving here and there. He was the single player. Now there are many in the global arena who have a role. And you have to figure out who is doing what. I mean, to be smart, to understand the politics and the dynamics, and to be able to connect and to create alliances and partnerships for change. And this is how I would like to end. A lot of great public health work has happened very often, but with short-lived effects, because those who initiated those projects, programs, strategies, policies, they didn't think of the day after. As a politician, for example, in healthy cities, we said, yes, Mr. Mayor, it's great that you are enthusiastic about healthy cities, but in 2 years you will be gone, or in another 2 years. You know, this thing can go down the drain very easily. So, could you get a council resolution that you all like across parties, this program? Could you get a partnership statement from various people, the Commerce Chamber and various other community organizations, political parties, create consensus for health in your cities for you to be able to have a sustainable future in your efforts to link health, social, and sustainable development in your city. So thank you very much, and I hope that you got some inspiration out of this. Thank you. Yes. So, are there any questions? Please.
Well, thank you for this inspiring talk, and I'm so happy finally I have a speaker who's I understand his accent. I would like to ask you more specifically whether you have any insights or any suggestions of how we can make the UN-based organizations more assertive in the global arena. For example, I read today that Secretary Ban Ki-moon, or the former secretary, he called the US health system morally wrong. Of course, in an interview in The Guardian, he said that after his tenure. Is there any way where we can increase that assertiveness while the UN leaders are in power?
Is it still on? That's a very good question. It was one of my bullet points. I feel that, starting from WHO, that we could be a little bit more courageous. You always have to balance, because remember, the difference between a UN-based organization like WHO is that we have the privilege of working with the governments. An NGO doesn't work with the governments, and so they can be more critical, they can make more noise. It's a big difference. So our privilege is persuasion, negotiation, to try to get the governments to work on things, but by working with them, we cannot be kicking them on the other hand and making statements on the press that this is an awful place and whatever, because then the deal is off. So, but I have a feeling that today, on a number of issues where there are some pretty bad violations of human rights, I think all organizations, including WHO, have to be more vocal. Of course, there is another side of it. If you overdo it, you lose the funding to your organization. I mean, it's very... Now, and there is another side to what I was also saying before. We talked about cities before. We said that so many determinants of health are locally defined and influenced. Well, to me, it's a mystery that we are preaching intersectoral. We are working with local governments, and every year in the World Health Assembly, the governing body of WHO, you only have delegations of ministers and advisors of ministers, staff from the Ministry of Health. Shouldn't we have ministers of education, environment? Shouldn't we have at least a mayor from a city to have a local voice in the World Health Assembly? I don't know if you, how can we change already the way we interact with countries by being faithful and true to what we are preaching? Because, of course, ministers of health who come to World Health Assembly, what do you think they're interested in? They're interested in medicines, in how to get their health sector and their health services adapt and to the current challenges. They have little space to engage further. We are lucky with some countries. Well, yes, if you're speaking to the Finnish and Swedish and Danish Minister of Health, they have plenty of time to listen to you. But try it with some other countries, very little. So it's nice to be able to talk to some other people in those delegations. But they are all listening like that to their head of delegation. You don't have other voices. So, but the UN, I think, I have a feeling it's going to be reinvented. Because in many ways, because of all these developments, it doesn't follow the way it is functioning. The potential of the demands and the priorities of our time. What Mr. What's the new one? Anyway, the new Secretary General is going to do, I have no idea. Other questions? Please.
Hi, I just want to say thank you very much for the talk. I learned so much. My name is Raha. I'm from Malaysia, and I'm doing my MPH here at BU. My question is, so when you mentioned a lot about the top-down approach, saying that that's the most effective because we're changing the policy, changing the framework that governments work in, what about like empowering the communities to like change at the grassroots level? And I guess in aiding that transition from like bottom to top, what are your recommendations? Thank you.
Well, I mean, since Alma-Ata, at least, the idea of community engagement, empowerment, participation, there is not only huge literature, but great examples of how to do that. In a new kind of governance context, what you want to create is not a top-down. You want to have a dialogue between the community interests. You want to basically work for health. You want to create preconditions or conditions that will generate health from across the sections of the society and the sectors of the government. And in that, it is not paying lip service to let's have also some community representatives. But you need to have platforms. You need to have frameworks where all those actors are able to contribute. There are good examples. We have tried many of those also in the Healthy Cities movement. I have seen countries which have done great things by not, as I said before, just in name saying we want to engage our community. Here is a plan we are planning to have in our city. We will welcome your comments in a week and that's it. I'm not talking about that kind of involvement. I mean encouraging also the creativity and the ideas to come from the community, as well as having a supportive policy environment that works for health. So it's essential. Please.
So I would like to turn this around just a little bit and do it private health to the policymakers that are at top. So if you have cases, it all comes down to capitalism.
To
capitalism, to making money. The governments want to save funds, and it takes time. Policy changes take time, especially here in the United States. That's why they're NGOs. But if you change the dynamic and the rhetoric when you go to talk to policymakers and say, well, you could save money here if you do public policy, which will bring in more maybe private money into your pockets, because these politicians want to line their pockets with money. That's all it comes to when it comes to the United States. If you look at the history, this country was built on capitalism, and nothing's going to change. So, you know, we need to come up with something that will say, you know, this case here, we have a case, an epidemic, let's say, in the city. Okay, you want to get your employee review for maybe a higher salary next year? You know, people are always thinking about it's all about the money here in the United States. So, you know, I hate, it's not being not being pessimistic, but I'm also being optimistic too. We need to start, we need to start thinking a different way when we approach the politicians that be, you know. That's just a statement. I'm not looking for an answer because there isn't one. You know, we just need to keep going out into the community. So I could get off my soapbox now. I'm sorry.
I think that's great. I mean, not to give an answer then, but just to maybe amplify the optimistic part of your statement, is to say that if United States is not an exception, I mean, there is such a variation of countries, and a lot of them are capitalistic countries that would, and many decision makers expect to know something about costs and gains. What we have failed to do is very often to make also the economic case of many of things that we say. There is some literature now that is talking a lot about the gains from preventative interventions in the short term. You know, we became public health practitioners listening constantly that politicians will never buy what you're selling because the benefits will come in 30 years, by which time they will be out of politics a long time ago. But that's not the case today. And I have to say, in addition to having some more robust economic data today, I think we have to come back to what I was saying before. What kind of society do we want? That's a debate. Where health is in our society. Health is a proxy for so many things in the way we live. It's an essential for fulfilling our aspirations. It is linked to every human activity. We cannot just, we have to demand this as citizens. We have to engage with our politicians. We have to get the professors and the others out in the streets to explain these things, to go and join political conferences and talk about these things. Maybe a lot of this literature on the determinants of health keeps moving around us, and it doesn't get, even by osmosis, to any of those people. So I think today we do have the evidence. We have some good examples, but we need to do something more than what we used to do. It's not business as usual. Please.
Hi, my name is Elizabeth. I'm also an MPH student. And I actually wanted to draw on your experience working and living in Copenhagen. Since, as you said, the government is very committed to health and they've been praised for their health outcomes, but the lack of population diversity and the relative size, really, there are obstacles to it being seen as a model for the rest of the world. So in your experience, which countries, or more specifically cities, would you say we should look to as emerging as leaders in pursuing true equity or encouraging competition, interacting with economics and capitalism, or providing a transferable framework for us?
I don't like labeling, you know, who is a capitalist. The Nordic countries are countries which are more equal. The gap between the haves and the have-nots, the rich and the poor, is much shorter. Societies that have a social consciousness, they provide, they support. But I will give you one example, since you mentioned Copenhagen. Copenhagen has probably the best cycling network in the world. 45% of the working population in Copenhagen goes to work by bicycle. There are people who come to Copenhagen and they say, wow, I mean, they are Danes, they are Nordics, they are Scandinavians, they are whatever. And I say to them, if you think that what you see today is because God created Copenhagen on the 7th day with cycling lanes, you are wrong. It took a lot of political fights, but the most important, it took great visions. These people, and it is not a unisectoral vision. A cycling lane in Copenhagen is good for energy, for transport, for environment, for health, you name it, for social interaction. But they had visions for which they fought, they shared them. They are a country which is thriving also economically, but they knew where to put their priorities. So, why does this happen there and it doesn't happen elsewhere? There are many reasons, but there are good concrete examples of countries who actually visualized the kind of society, the kind of living environment they wanted. My daughter, who is 18 today, she was born in Copenhagen. Now she lives in France. My wife is French. And I was trying to inspire her to feel Greek, but I have failed. But when I ask her, she lives, we have our home in Toulouse. But when I ask her, where does she like to live? She says Copenhagen. And because it's a place, it's not only the place where she was brought up, but also because it's truly a place built for people in every respect. Now, that's a vision. It's not accidental. And this is something for which many people have fought politically, but they share that vision. So you may have differences between the socialists and the more conservatives as to how to approach certain things, but there is a common vision of that society where it wants to go and how it sees its future. Sir, one more question.
Hi, thank you very much for your talk. You mentioned a lot about how public health organizations should work with policymakers and the government, but a major player and stakeholder is the private sector. Could you elaborate on how the World Health Organization has in the past or should moving forward work with the private sector, such as pharma, who plays a huge role in healthcare today?
Very short answer of that. When I joined WHO, talking about the private sector was a big no-no. We don't talk about private sector here. We're not getting involved with interests and so on. Today, when it comes to envisioning the provision of healthcare and so on, I'll give you only a general kind of statement. It's for as long as it is based on standards and principles which are well defined and methods which safeguard safety and whatever access and so on, private sector can work very well within a system where you have public-private partnerships and so on. When it comes to pharma, it's almost like a schizophrenic kind, amphithemic kind of relationship, because of course we need pharma, but pharma also has its own interests and it's driven by profit and so on. So this is a carefully balanced relationship. It's a necessary relationship. You cannot, we depend on that. And of course, when it comes to investments, I mean, today when you have the AMR huge threat in the world and you want pharma to invest much more into new antibiotics, etc., and they may prefer more lifestyle and other investments in drugs and so on. Of course, these are big issues. But today, the private sector is much more closely linked with the public, and there are some good examples. Thank you.
Just a quick note on the private sector. For next week, you may have seen we actually have a symposium on private sector working with academic public health, where a lot of these issues that Dr. Tsouros mentioned will be discussed, hopefully. I think it'll actually be a very interesting discussion. I think there are really important questions on that, so thank you for raising that. Please join me in saying thank you, Dr. Tsouros.
Thank you.
And,